So our project became a joint effort with the university having a role, and then pretty rapidly connected up with an organisation in Tairawhiti called Te Wū Tairawhiti, which is, I think, a partner organisation for Sustainable Hawke's Bay here in Hawke's Bay. And so Te Wū Tairawhiti and Sustainable Hawke's Bay being the community part of this project. Ministry of Health was especially interested in the health impacts of the cyclone in Tairawhiti and Hawke's Bay. So it's been a project about Tairawhiti and Hawke's Bay. My own pathway into this, I've been personally involved in the intersection between environment and health for, well, a personal landmark was the start of an organisation called Aotearoa, or the New Zealand Climate and Health Council. We had to pick a name, and we found council on the name. That might make it more persuasive in our attempts to influence policy. So there you have it. But Aotearoa is our name, which translates as pretty much as environmental health, is what we're translating it. And so that's a organisation, I suppose it's my non-governmental home, as well as working at the university and the hospital, but I always like to mention Aotearoa. Anyone aligns with their professional roles with health, then there's a place for you. Actually, the further you go in health, the more you start to feel that health is all-encompassing. Health, well-being, order, life, same word in reo Māori. Health is all-pervasive. And I just one more time, I'll say, anyone wants to join Aotearoa, you're very welcome to. It's very easy to sign up. You just look for us on the internet and sign up there, and we have a monthly meeting on a Thursday evening. However, in this role, my capacity is with the University of Auckland, where I work in cancer. This is our authors on the project. Research into health and wellbeing impacts of adverse weather conditions. Short title: Te Wū me te wai. Te Wū is Te Wū Tairawhiti, which is been the Tairawhiti part of our community partnership. And that word "wū" means it's like a rootlet or a little fibre or a little hair that comes off a root. So it is the immediate point of contact between plants and soil. And then, of course, water circulates around those. And that's us, you see, Te Wai. The water, or the University of Auckland is Waipapa Taumata Rau is the name for the University of Auckland, but you can shorten that to Te Wai. So it was a way of shortening down the name of our project into a shorter form that also made us think a bit about what our project was about. Intersection between university and community, intersection between living plants and the environment that they are in. What's that got to do with cancer? So my own, I've mentioned my interest in climate and health, but you probably picked up my own sort of personal orientation that all these things, they all connect to each other one way or another. You know, even cancer connects to these things. But my own project in cancer is all about bringing cancer services more into the community. So I'm a medical oncologist, I'm a chemotherapy doctor. I do that a day a week now, well, plus a bit more, I dare say, at Auckland City Hospital. but then I'm with the university, and then I'm with a project to get our services more into the community. We've tended to be based inside the hospital, but there's been quite a few shortcomings with how the Cancer Experiences works for people, families and communities, and the basic idea is if we could be more present in the community, probably the experience or the journey with and around cancer would work out better. So I was real glad to hear those words earlier on today, talking about the value of building communities, because that has very much been, I believe, the orientation that we went into this work with. And one of my own beliefs about health care, of course, is far from the totality of health, but one of my beliefs about healthcare is that one of the things about accessing healthcare is you have to build relationships of trust, and so healthcare, by its nature, is something that's going to work towards strong communities that depend on people talking to each other and having relationships of trust. So I kind of hope that what we do with the health care system or the health system could be instrumental in building communities. Hidia Philip Barbara, who's from Tūranganui in Gisborne, wrote the mihi for our project. One of the awesome things about this project was we were granted a sum of money from the Ministry of Health, and we split it 50-50 with the community partners, and so half the money went into the communities, and that involved standing up community research workforce. So we had people who, in Hawke's Bay, I think it was a bit different because we had people already familiar with qualitative research, interviewing processes, but in Tairawhiti, that workforce of new researchers was trained up on the spot especially by a woman called Holly Thorpe, who's a professor of sociology and experienced researcher, trained up a workforce of new qualitative researchers in the community in Gisborne, and Hidia is one of those researchers, and she wrote the mihi for our report. Just a little bit more in the spirit of avoiding screeds of text. If I'm not obsessed with research and writing up reports and cancelling the rest of my life so I can finally finish this report and hand it over to the ministry, these are the types of things that I would much prefer to be doing. Especially the bicycle, I've seen quite a bit of the country on a bicycle, and I've been around this coast on a bicycle. I'm very glad to have been able to do that in my time. So, into talking about the project itself in a bit more detail. I just wanted to say I'm conscious I've been talking, I suppose that's why I came here, but it might be that along the way people have got a question or something, and we figured we'd welcome interaction. At the end of the actual presentation, myself and John, we're going to turn into the panel, so that'll be another way to interact. But if you want to say something before then, by all means, chip in. Cyclone Gabrielle made landfall at February the 14th last year, and journeyed across the top part of the country and cut a swathe, of course, first through Northland especially, and then very much so in the east coast of the North Island. The cyclone stands out, but of course it wasn't the only event. Around about that time last year, there was a string of extreme weather events. Auckland had been through its own flooding events, and then Gabrielle arrived here, And then there were subsequent events. We've been talking about this project both here and in Tairawhiti, and around there they talk about subsequent events as son of Gabrielle and son of Gabrielle, and then they just kind of stopped naming them after a while. But the rain, there was Gabrielle, and the rain kept coming. I referred to this thing called the Sendai Framework for Disaster Risk Reduction. The Ministry of Health was interested in this international instrument called the Sendai Framework, and asked if we could organise our project around the Sendai Framework, which is the main instrument of the United Nations Office for Disaster Risk Reduction. And that seemed very reasonable to do. The Sendai framework has got 4 parts: understanding risk, governance for risk, resilience for recovery, and preparedness. So that this is a way of organising thinking about disasters and reducing the risk from disasters. And at the request of the ministry, but very reasonably, that became an organising principle for the project that we did. And then the questions we went into this with is, what were the main contributors on health and well-being of people and communities in Tairawhiti and Hawke's Bay after the cyclone? And then how can this experience be drawn on in the recovery and in future? So this was the thinking at the start of the project. A bit more on background and just about the nexus between climate and health. Been quite a lot of thinking about this sort of thing over the years. And logic models like this one. I like showing this one because this is one of the early ones to be published about connection between climate change and health. This came from the World Health Organization in the 1990s. It's called the DPS-EEA framework. I suppose you might say deep sea. Driving forces, pressures, state of the environment, exposures, effects on health, and then leading into ill health categories and social and economic impacts. So I just refer to that type of logic model as one way of thinking how the changes in the environment can play out human experience. Like all models and ways of thinking about things, these can be criticised and improved upon, and so there's been later iterations of this type of model. One thing that I personally feel that is missing, or one thing that I think could be brought out better from these types of logic models, is the simple fact of chaos. So when there is disruption to social and community systems by events of whatever type, you just can't do what you normally do. And at a very basic point, if you don't have a bridge and you don't have a road, then you won't be able to access care, so you won't be able to run a cancer service. And so cancer doesn't appear in a box in that logic model, but it's everything falls apart. So at the moment, once your society grinds to a halt on account of disruptive weather events. Another slide, which I'm sure everyone will be familiar with, is the concept of the planetary boundaries that humanity's currently breaking, to put it mildly. And of course, CO2 and climate change is just one of the disrupted planetary boundaries that we have to deal with. In our project, we wanted to investigate the health and wellbeing impacts of Cyclone Gabrielle on people and communities in Hawke's Bay. We wanted to record the stories of people who were affected by the cyclone, and we wanted what could be done to reduce the impacts of extreme weather. And we did this with two main angles. The first angle I won't go into in a great amount of detail just now. The first angle, in a word, could be described as quantitative or numerical. The second angle was qualitative or verbal. But for the numerical part, Te Whatu Ora, Health New Zealand, provided us with their entire data set for 6 years. So every time a person interacts with the state in its manifestation as a health system, because every person who does that in this country receives a unique identifier called a National Health Index number or NHI number, every single interaction is recorded. And that's recorded primarily, as I understand it, for the purposes of the health system keeping track of what it does so that it can be sensible with its financing and planning. So primarily for business purposes. But in fact, those data that are collected that way, you can learn a huge deal from them about after anonymisation, but still retaining the demographic covariates, so still retaining the demographic information, you can learn a great deal about the different communities, populations, people who access to health system and what they did, where that happened and when that happened. So the data sets that we were able to study for the last 6 years include again, anonymised, every single outpatient attendance, every single hospital admission with the list of diagnoses that were recorded when people were in hospital, every single medications dispensing, every single laboratory test. These are called the national collections, and they are part of New Zealand's public sector data ecosystem, and so long as you can establish that you're going about your project in the right way, then it's possible to access the national collections and learn from them. This slide is just a few tasters in terms of the quantitative side. And just bearing in mind that over the last 6 years, dating from the 2018 census, comparatively recently, there was a cyclone catastrophe, but in the middle of that time, there was a pandemic. There was the first arrival of COVID. There was a quiet time for our country for a couple of years. Until the arrival of Delta, and then of course of Omicron around early 2022, and then a year later the cyclone. So in terms of understanding the numbers of what happened, it is quite interesting to ask the question, well, what effect does a cyclone have compared to the effect that a pandemic has, for example? So these are the types of things that you can look at with the numbers. In fact, it looks as though, at least in the immediate aftermath, the level 4 alert phase that happened in 2020 with COVID slowed activity down more than the cyclone slowed activity down in Tairāwhiti and Hawke's Bay. It's a very high level, very preliminary sort of result, but it's, to me, illustrates why it's interesting to be able to look at 6 years of information with some very major events happening during that time and think about the different profile of those events for how you run your service. What have I got? A couple more slides there. Here, the lower two slides. If people could only know the amount of pain that's gone into generating those slides from the data. But anyhow, we got there. I'm pretty happy with them. The one on the bottom left is about the utilisation of antenatal blood testing over the last 6 years. Whenever pregnancy happens, it's important to have some blood tests in the early stages, and we can see that information in the laboratory test collection. And so then you can ask the question, does that happen? Did the cyclone have an effect on that sort of activity, for example? And then the one next to it is about a thing called ASH, which is a type of hospital admission which is thought to be mostly avoidable. How does that change over time? Because we can keep track of those. A lot of peaks and troughs in the profile of avoidable hospital admissions in babies over the 6 years. This is why I've, to be honest, it's part of the reason why I cancelled my trip to Australia. That and the carbon implications, but still working through this stuff. And then up here is the thing about drive times if you want to access primary health care with GPs. And stands to reason if your residence is in a settlement or a city, you've got a shorter drive time to access care, whereas if you're in the back blocks, Waikaremoana there, you've got to drive for a lot longer, which becomes further compounded once you start knocking out bridges and roads. So that's the numbers part. In the final part of the talking bit, I'd like to talk about what people said to us. We asked people to tell their story. We asked about what happened to them, their whānau and friends, how the cyclone affected them physically, emotionally, financially. They often told us how it affected them spiritually, socially, how they coped, how their life and work has changed, what they were worried about, what maybe they're still worried about, what they felt about the supports they had and have, and the extent to which their access to healthcare was affected. It's the belief of all of us that all of these questions are very relevant to health. If you don't have your life as a whole in a good place, that definitely has implications for health. So all of this becomes very relevant. There's a slide on the right about our data protection process that we used for this project. Anyhow, we identified 4 groups of people, especially in Hawke's Bay, with the process taken for the research in Hawke's Bay. This talk does have an emphasis on how our project is played out in Hawke's Bay. There's a slightly there's a comparable but also to some extent contrasting story for Te Tairawhiti. And that's been a very interesting part of the project as well. It, to my mind, reflects that we have 2 regions in this project and 2 not necessarily identical ways of looking at things or thinking about things. There's certainly enough parallels and the points that matter, but anyhow, today I'm emphasising more the track that we took for the Hawke's Bay part. So 4 groups of people. One's moderately or severely impacted by the cyclone. That was described as personal. And then we had community groups. And then third one, emergency responders, heavily involved in the immediate response, and then professional providers of healthcare. And that was 60 people interviewed. And here I must acknowledge John and his team who did this interviewing. I interviewed exactly one person in this project. So the interviewing part of this project, massively grateful to the community research teams for that. Each interview was at least an hour and included people, different ethnicities, different areas of Hawke's Bay, different areas of healthcare, different roles, ages, occupations, and people with disabilities. The photographs actually from our Tairāwhiti team tell a bit of a story with pictures about the process of organising all the information that came together from talking with people and then disseminating it back. What do we find? So with qualitative research, there's a thing called thematic analysis, and so from what people said, we could draw forth 5 themes, inevitably, if you have a different team of researchers, you might come up with a different thematic analysis, but it is how qualitative research really works to start organising and making sense of the large amount of testimony when you talk with 60 people in Hawke's Bay and comparable number in Tairāwhiti. So the themes that we distilled out: health systems, personal health, people at risk, activating communities, and then another one which we've called action stations, which is about doing things. So, and then within the themes, there are sub-themes, as you can see on the slides. And I feel it's probably better if I don't read out the whole list, since those are on the slide. I hope everyone can see that. Probably might not be able to see the whole slide. But some of the things that have stood out for me personally, the strength of Māori communities in this, this one, the power of a cup of tea. So many people so often talked about the power of a cup of tea, wā kapi tea, in a time of stress, and and ultimately dawning awareness that climate change really is here and really is a thing. I think there's still, I think we still have a task ahead of us, to be honest, with keeping that awareness in people's eye about climate change. I've got some slides with some quotes from people. I'm not quite sure how to go with these slides because there's quite a lot in the quotes. I might just put that there and let it speak for itself for a moment, and I might flip on to the next slide, maybe come back to some of this stuff at some point. We're around and we always have to front our whānau, so we weren't going to let up. Children with nightmares when the rain happens, it is still a thing. Type of toll on communities and community organisations, from the mental toll of getting through and putting the pieces back together again afterwards. You need someone you can go to vent to. Access around the region. I thought we were going to die. So As I said, in the panel part, I'm sure we can talk some more around what people have said to us. Anyhow, we've drawn together some recommendations to bring back out of this, fall into three groups: empowerment of communities, hubs in there. So it's good to see the word hub used around here as well. Getting health services into the community, and earlier on, about my own beliefs about why health services in the community is a good thing for communities themselves. And then a set of recommendations about procurement, which is, procurement is one of those words, sounds a bit, it doesn't seem to be talked about as much as it could be, I think, but the suitability of the gear and the equipment that you have when extreme situations do happen. That's all part of how we do our planning, and decisions are made about how we're going to spend our money and what we're going to spend it on. And if we can make those decisions with an eye on mitigation and adaptation, we should be. Especially when communications went down, especially when power and water went down, when the supply of medicine stopped, when transport wasn't available, and when people just weren't available because they were stuck on the other side of a raging torrent. Procurement decisions, often made in a kind of greyed out office environment, sort of imagine it. Those decisions really come to life in a crisis. All right, so that's my primary set of slides. There's a few more slides after this. That one was taken at sunrise from East Cape Lighthouse at the start of a bike trip from East Cape to Taranaki a few years back. It's called Kōpiko Aotearoa. Recommend that to anyone who's interested in a long bike trip. But it seemed quite a good note to complete the talk as we think about what are we going to do now. So I've got a few more slides with some recommendations, but I think I'll park it at the point just now, and I think we can move into some back and forward panel time, if that's acceptable to everyone. So thank you so much for hearing me out. Kia ora, tātora.